Good evening, everyone. How are you all? Okay, so let's start our tonight's session. So we finished the orthopedics class 1, right? So we are going to finish ortho today, most likely. If we can go very fast, we should be able to finish it. Now we are going to start from pain in the arm and hand, because last class we finished up to the shoulder pain, right? One of you, I think last class, asked about open fracture management. So I want to go through that a little bit so that you know, because I can see that there are some questions coming from here. So for open fracture management, this guideline explains it quite well. So you can go through this. I'll also put the link in here. Okay. So this is actually that link. I have put it in the chat box. So you can have a look. So let's talk about open fracture management. So open fracture means that you can see that there is an injury where the bone or the fracture hematoma are exposed to the external environment. That means if you can see that there is a puncture wound, and sometimes even you can see the broken bone is visible, that's the open fracture. So once you get an open fracture in the exam, you need to know how to do the step-by-step management. So with the significant trauma, resuscitation and stabilization is the most important thing. So what do you mean by sound is not clear? Should be fine. There is nothing we have changed. Okay. Let's move on. So with a significant trauma, resuscitation and stabilizations are the most important things. So if a patient having a severe trauma, then your first job is to resuscitate the patient. After you have stabilized the patient, open fracture should be addressed emergently. If there is a vascular compromise, thought to be secondary due to fracture fragment compressing a vessel, reduction of the fracture should be attempted immediately. So this is what I told you last class, that if you see that there is a vascular compromise, that means patient having a severe ischemic pain in that area, or there is lack of pulse, that means there is a vascular compromise. Most likely the fracture fragment is compressing the vessel. So in that situation, you need to do the reduction as soon as possible. After that, wound should be thoroughly irrigated with at least 1 liter of saline. So the next step is wound irrigation. And the limb should be immobilized in a splint. So these lines are important, and all I need you to understand that this is the step-by-step approach. After you have done the irrigation and wound debridement and everything, antibiotics should be administered as soon as possible. Okay? And antibiotic, there are lots of antibiotic you can use. The tetanus status of all patients should be assessed. If a patient did not have a tetanus injection in the last 5 years, then you are going to start the patient with a tetanus toxoid. And then an orthopedic surgeon should be consulted immediately. Okay, so reduction if there is vascular compromise, then definitely if the patient is in pain, you will give some painkiller. Irrigation of the wound or wound debridement, antibiotic, and then followed by tetanus. Does it make sense for everyone now that what will be the step-by-step management? Yeah, good. So now we move on to the painful arm. So first of all, this is your, we are doing from John Murtagh. So chapter 53 from 8th edition is this chapter. So if you want to open that from your John Murtagh, you can also do that. So pain in the arm and hand, very important chapter. First of all, pulled elbow. So pulled elbow mainly happens in children below 8 years. So if somehow you suddenly you pulled a child hand at the wrist, what you're doing is that you are actually giving a sudden traction. And when you do that, sometimes the radial head, so this is the radius, the radial head can be pulled out through the joint. So basically you are just doing a displacement of the radial head from the elbow joint. And that is what we call pulled elbow. Okay? So patient, obviously the child will be crying, child might not even want to use that side of the arm. The elbow will be slightly flexed and pronated. So an X-ray is not needed to make the diagnosis. So there will be a history that maybe like someone pulled the child through the wrist, and then after that the child is having pain in the elbow, not moving that side, even not able to do the flexion extension, and then child is keeping the arm as flexed and pronated. If that is the case, your next step is to just do a reduction. So you'll need to do a reduction by any of this method. There is supination method and lots of other method which you don't need to know. So the management is reduction. And reduction can be done in a GP clinic. You don't need to do any anesthesia or anything for that. Okay? And that's the treatment. So there is no need of any X-ray for this. All you need to do is to do the reduction, which means you need to put the displaced radial head back into the elbow. Moving on to the next one, which is tennis elbow. Tennis elbow is also known as lateral epicondylitis. So there are two kinds of epicondylitis. One is lateral and then there is a medial. The lateral epicondylitis is called tennis elbow. Medial epicondylitis is called golfer's elbow. So this tennis elbow is nothing but a kind of a excessive or overuse of the extensor muscle of the forearm. So if someone is doing a lot of wrist extension movement, so if you are playing tennis, it involves a lot of wrist extension, right? So patients who is doing any job, or if the patient is playing tennis, which involve a lot of wrist extension, and they're coming to you with a pain in the outer part of the elbow along the lateral epicondyle, then you can think of tennis elbow. So tennis elbow is common in carpenter, bricklayer, cleaner, gardener, dentist, and definitely someone who plays tennis. Pain at the outer elbow, pain in the elbow during gripping movement. So if you do any kind of wrist extension, that means turning the taps, turning the door handle, so anything which involves gripping movement, it can aggravate this pain. And if you palpate over the lateral epicondyle, that will be tender. So localized tenderness can be found on the lateral epicondyle. And if you do a passive extension of the wrist, patient will be in a pain. Or if you do a resisted extension of the wrist, that means against your hand, that can also cause pain. So basically anything which causes like a bit of a stressing of the wrist, especially wrist extension, and if patient complains pain on the lateral side of the elbow, that's tennis elbow. So to diagnose tennis elbow, you don't need to do anything. No need of X-ray or ultrasound. it's a clinical diagnosis. So it can take even 24 months to get better. So initial treatment is rest from offending activity. You can also ask them to apply ice, sometimes compression or elevation. You can give them some painkiller like paracetamol, NSAID, and then send them for exercise. Okay. Sometimes we also ask the patient to put a below elbow pad. So if this is the elbow, they can put a pad over here because this is where the tendon gets strained or tendon get inflamed. Okay. So you can ask the patient to put on a below elbow pad. And you can see these are the three important signs that you can find in lateral epicondylitis, which is the same thing. Tenderness on the epicondyle, passive stretching will be pain, or resisted extension will be painful. So I have written in here rest, analgesia, exercise. You can even send them for a steroid injection, below elbow pad or below elbow band, and then last resort is surgery. Okay, so that's your lateral epicondylitis. Now there is another condition called olecranon bursitis. So you can see that this is the olecranon process of the elbow, the bony prominence that you can feel on the elbow. That's olecranon process, and on the top of that there is a fluid-filled sac, which is olecranon bursa. Sometimes this bursa can get inflamed, and patient can come with a painful lump on the elbow. So that's olecranon bursitis. So it's a swelling localized to the bursa over the olecranon process. It could be caused by a trauma. Sometimes even patient who has rheumatoid arthritis or gout, they can also present in the same way. So what would you do in here? Because septic bursitis is also one of the differential diagnoses. So if a patient having systemic feature, or if you are concerned about a septic bursitis, like there is an infection into the bursa, then in that case you need to do an aspiration of the fluid and send it to the laboratory for microscopy and culture. For olecranon bursitis, there is no specific treatment. If it is related to injury or trauma, you can give them some like painkiller. You can ask them to take some anti-inflammatory to reduce the swelling. Okay. If it is due to infection, definitely patient will need a IV antibiotic. Next, carpal tunnel syndrome. Very, very important for exam. So CTS is entrapment of the median nerve. So this is the carpal. So this is the carpal tunnel. You can see underneath the carpal tunnel, the median nerve goes into the hand, and median nerve supplies this thumb, index finger, middle finger, and half of the ring finger. So 3.5 finger on the palmar side of the hand. So this is palmar side is supplied by median nerve, and this 2 finger, that means 1.5 finger, is supplied by ulnar nerve. Okay. Now, carpal tunnel syndrome is entrapment of this median nerve under the carpal tunnel, and patient will complain pins and needles involving these fingers. Okay. So there are lots of causes of CTS. Most of the time it is just idiopathic, but it can be due to diabetes, sometimes hypothyroid, multiple myeloma, pregnancy. So lots of causes are there. So the pathognomic sign of carpal tunnel syndrome is that patient will say that they wake up in the middle of the night because they feel pins and needles on their finger. They get out of the bed, shake their hand, and then the pins and needles will subside. So that's one of the very important feature of CTS. So if you suspect CTS, what would you do next? You'll do a physical examination. So the physical examination that we do is called Tinel test and Fallon test. If Tinel or Fallon is positive, there is a likely possibility that it could be a case of CTS. There is another test better than those two tests is 2-point discrimination. So the test has the highest specificity of all the clinical tests. Okay, so the best is 2-point discrimination, and then the initial would be Tinel and Fallon. So let's say clinically you think that this is a case of carpal tunnel. So what would you do next? If you want to confirm, you can first start with an ultrasound. An ultrasound not always the best test to confirm the carpal tunnel syndrome. Many times it can miss it. So your initial investigation can be ultrasound. And if ultrasound is still does not give you the confirmatory finding, then your best test to confirm CTS is nerve conduction study or electromyogram. So NCS is usually the one that can confirm carpal tunnel syndrome by it can be confirmatory test. So what is the treatment? Treatment depends on the severity of the pain. For mild cases, just simple rest and splinting at night is sufficient. You can also go for a carpal tunnel injection of the steroid. So you can put a steroid under the tunnel to reduce the inflammation. And the last option, especially for severe case, is surgical release. So surgery is always the last resort. So for a patient such as like this, you can give them short-term oral steroid and local steroid injection. Okay. NSAID, diuretics, wrist splinting are not super beneficial, but you can always try. So if they're asking about the initial management would be like rest, splinting at night, and then you can also go for a steroid injection, and also you can give them some oral steroid. Okay, so that's the treatment, and then the last option is surgery. So that's carpal tunnel. Moving on to trigger finger or trigger thumb, also known as flexor tenosynovitis. So what is trigger finger? So it looks something like this. So trigger finger, it's kind of a work-induced condition. It is also known as flexor tenosynovitis. Why it is called flexor tenosynovitis? Because this causes a flexion deformity of the thumb or other finger, and patient needs to manually extend the finger. So finger will be locked in the palm of the hand, and finger can only be extended manually. So if that is the case, you can diagnose this just by looking at this. Even sometimes they have this kind of a nodules that they develop on the tendon, and you might be even able to feel this nodule on the palm. So trigger finger is commonly associated with type 1 diabetes, rheumatoid arthritis, gout, hypothyroidism, amyloidosis. So in middle age, these tendons, which rapidly and constantly being flexed and extended, sometimes can have a wear and tear, and then it forms this painful swelling and a nodule. So trigger finger is nothing but a work-induced repetitive flexion and extension of the finger, causing this flexion deformity of the thumb or any finger, and patient needs to manually extend it. So it is usually a clinical diagnosis, but if you want to confirm it, you can do an ultrasound. The treatment, so if patient having pain, you can start with paracetamol and NSAID. That's the initial treatment. And then you can also go for a steroid injection under the tendon sheath, not into the tendon. Okay, so under the tendon sheath, you can go for a steroid injection, and that is a very good treatment for this case. And the last option is definitely surgery. No, triggered thumb is not common in kids. It's common in patients who are a bit of elderly patient, because it's a wear and tear of the tendon. Okay. Next, Dupuytren contracture. So Dupuytren contracture is like this. So you can see the finger is getting quite flexed. So what is Dupuytren contracture? It is a fibrous hyperplasia of the palmar fascia causing a nodule formation and contracture on the finger. So basically, this is kind of like the palmar fascia gets thickened. And when it gets thickened, it can start to pull the finger. And the finger can have this kind of contracture. Sometimes the initial would be just contracture like this. But if it is the very severe one, it will have like contracture like this. Okay, now that is very bad. And this needs surgery. So it occurs in male over 65. Cause is unknown, but there is a autosomal dominant predisposition. So family history is important. It can be also associated with smoking, alcohol, cirrhosis, COPD, diabetes, epilepsy, and heavy manual work. Okay. So what would you do for a Dupuytren contracture patient? Again, it's a clinical diagnosis, but if you want to confirm, you can also do an ultrasound to confirm the diagnosis. So the treatment depends on the severity of the contracture. So let's have a look. So Ortho Bullet has discussed a little bit more detail about this Dupuytren contracture. Questions come from here, so you need to know a little bit more about it. Okay, so the treatment includes non-operative and operative. If there is no functional impairment, and then even there is no contracture, just a nodule that you can feel on the palmar aspect, there is nothing you need to do. Just observation is all that the patient needs. You can even send them to an occupational therapist or a hand therapist in this time. When patient starts to get a painful nodule, that's the time you can go for a steroid injection into the nodule. Now, collagenase injection is a very good way to treat this, especially if the patient has got like mild contracture. So if a patient has got MCP contracture rather than PIP contracture, in that case, you can go for this collagenase injection. So what do I mean by it? So this patient has got contracture of the metacarpophalangeal joint, right? Not much of a contracture of the interphalangeal joint. In such situation, you can still go on for a collagenase injection. But this patient, not this one. So the patient that I have shown you, like this one, who has got PIP contracture, for that patient, collagenase is not the best option. For that patient, you will need to go for surgery. So there is a non-operative treatment also. We call it percutaneous needle aponeurotomy. So that's also one of the things that can be done. There is a condition called partial palmar fasciectomy. And then also we have like total fasciectomy. So fasciectomy means that you remove the fascia which has got fibrous or which has got hyperplasia or thickened. Fasciectomy is only indicated if there is significant contracture, especially if there is a PIP contracture like the picture that I have shown you. For other patient who has got mild contracture, especially at the MCP joint, you can try collagenase, you can try steroid, you can try needle aponeurotomy. Okay? Does it make sense for everyone? So if the question give you a picture like this, in that approach will be, if the patient having pain, you can give them some painkiller. You can also send them to a hand therapist to start doing some exercise. And then after that, if it is a painful nodule, then a steroid injection. If not, just this contracture is there, you can even go for collagenase or needle aponeurotomy. Needle aponeurotomy is better than collagenase. If it is contracture like this, then fasciectomy is the treatment of choice. Okay. Next, D. quervain tenosynovitis, or also known as washerwomen's sprain. So this is also work-induced condition. So D. quervain tenosynovitis, it's kind of like the first extensor tendon of the thumb, which goes from the wrist to the base of the thumb, gets inflamed. Let's have a look. The picture will be really easier for you to understand. So you can see that this is the thumb, and this is here you have got two tendons. So over here you have got extensor pollicis brevis. Extensor pollicis means thumb, and extensor means extension. That means this tendon extend the thumb. And abductor pollicis means which causes abduction of the thumb. So extensor pollicis and abductor pollicis tendon is over here, and on this side you have got extensor pollicis longus. Now, patient who has this D. quervain tenosynovitis, these tendons get inflamed, especially the extensor pollicis brevis and abductor pollicis longus. So have a look, this one. So the tendon that goes over here, that gets inflamed. And so who will get it? Patients who is involved with a lot of thumb movement. So especially washerwomen. So any activities which involves a lot of thumb movement, they can get these two tendons inflamed. Okay. So when extensor pollicis brevis and abductor pollicis longus, which pass through the base of the thumb or through the wrist into the base of the thumb, it's inflamed. That's D. quervain tenosynovitis. So typical age is 40 to 50. The pain will be along the radial or along the lateral part of the wrist at the base of the thumb. Okay. So pain on the thumb and wrist movement. There will be a severe dull aching pain. Pain during pinch grasping. So if you ask the patient to do a pinch movement, they will have pain. So the very easy way to diagnose this is that if a patient coming to you with a moderate to severe thumb pain, and you can see that patient mainly having trouble to do any thumb movement, then you would be thinking of D. quervain tenosynovitis. Not on anatomical snap box. Anatomical snap box, mainly if it is tender, then we think of a scaphoid fracture. But again, the border of the anatomical snap box is made up by this tendon. So patient can get a bit of tenderness over there, but the tenderness will be on the tendon itself, not into the snap box. Okay. So the tenderness and sometimes even a crepitation just over and proximal to the radial styloid. Let's have a look. So where is the radial styloid? So this is where the radial styloid process is. So the pain will be on that area. So you can get tenderness and swelling over the radial styloid. And then there is a test that can be pathognomic for this condition called Finkelstein sign. You don't need to know what it is, but remember, if in the stem they say positive Finkelstein sign, then you know it is D. quervain tenosynovitis. So the treatment, so there is nothing you need to do to confirm the diagnosis. It's a clinical diagnosis. So rest and avoid the causative stress. So rest is the first thing. You can also put the patient in a custom-made splint, which will immobilize the thumb. A trial of NSAID for a few days. You can even give a steroid injection in this patient. Okay, and last of all, surgical release is the last option. So treatment is more or less same in most of the cases, right? Next, mallet finger. Also commonly asked in the exam. So it is a common sport injury caused by the ball, like football, cricket ball, baseball, unexpectedly hitting the fingertip and forcing the finger to flex. So it's kind of a hyperflexion injury to the distal phalanx. Let's have a look. So many of you might have got it. So if suddenly a cricket ball hit the distal part of the finger and it causes a hyperflexion injury, that's mallet finger. So it's a hyperflexion injury to the distal phalanx causing a rupture of the extensor insertion into the dorsal base. So the easiest thing to remember is that if a ball hit the tip of the finger and patient is no longer able to extend the distal interphalangeal joint, so no longer they are able to extend the finger at the DIP, that's mallet finger. Kind of a swan neck deformity, right? So what would you do for this case? So you'll just need to bring the finger as extension and you do this bandage kind of a, you can see this kind of, so you just make it extended and then put a bandage and keep it there for 6 weeks. That's the treatment. You don't need to know the detail about the test. You only remember the name of the test for this part 1 exam. Okay, so that's all about arm and hand pain that in the exam it can come. Everything that I have discussed is important. So all you need to know is exactly what I have discussed, nothing more than that. Okay? Any questions? Okay. Moving on to the next topic, hip, buttock, and groin pain. Yes, Raynaud phenomenon is important, but I think we discussed this in connective tissue disorder. So hip pain in children. So we did pediatrics already, but we did not cover the hip pain, right? So let's talk about hip pain in children. So the common pain in the hip for a child that you want to rule out is developmental dysplasia of the hip, then transient tenosynovitis, Perthes disease, septic arthritis, osteomyelitis, and SCFE. So comparison of important causes of hip pain in children. So this is a very good chart. It gives you a good idea about this common hip pain in a child. So DDH is common between 0 to 4 years. 4 to 8 years common is Perthes and transient synovitis. And in an adolescent, common is SCFE. So that's slipped capital femoral epiphysis. All of these patients will come to you with a pain and limping. Especially the pain will be around the hip joint. And they will have limited movement because of the pain. So abduction is the main one which will get affected. And also sometimes internal rotation and sometimes all the movement can become restricted. Okay, let's just start with the DDH. So DDH is when the femoral head dislocate from the hip joint. If we see here, so this is a hip joint, you can see, right? And you can see the femoral head. So this is the femur and it's the head of the femur. It's well located into the pelvis. So that's normal. But if you look on this side, you can see that definitely the femoral head is dislocated. So when femoral head is dislocated like that, that is what we call as developmental dysplasia of the hip. So it is common in female firstborn with a positive family history, and sometimes even patient who has like children who had breech delivery or transverse delivery, and also patient who had a cesarean section. So female child get it more than the male child. You can see 6:1 ratio. So definitely it is a symptom in a child, and most of the time you need to find this out as soon as possible after the birth. Okay. So what normally we would do, so every child in Australia, you need to do a full examination, like a neonatal examination after birth and then 6 weeks after birth. So during this time, you will be checking for developmental dysplasia of the hip as a general checkup. So what we normally do is we do these two tests called Ortolani test and Barlow test. This Ortolani and Barlow test is the one screening test that will give us an idea that if this child can have DDH. So this is usually positive in the initial 2 months after birth. So it's negative after 2 months. So after 2 months, if you want to confirm DDH, what would you do? You do ultrasound. And even if your Ortolani and Barlow is positive, you can confirm the diagnosis by ultrasound. So usually up to 6 months, we will be doing ultrasound to confirm DDH. And after 6 months, you can do X-ray if you can. So the screening test is Ortolani and Barlow. Plain X-ray is usually not the diagnostic choice for DDH. Ultrasound is usually recommended. And if ultrasound confirms there is a possibility of DDH, you need to refer them to a pediatric orthopedic surgeon. Because if it is not detected early, the femoral head will stay out of the acetabulum, and after the age of 1 year, child can have it delayed in walking. Okay, so delayed walking can be caused by this, so it is a very important thing not to miss. Treatment. So if you find this out in the initial 6 months, then put the patient in a pelvic harness or abduction splint. If it is 6 to 18 months, so in between this time period, you might need to send them to a, so the orthopedic will do a reduction followed by cast, and more than 18 months will need open reduction. The problem that if you don't treat this early, this can go into acetabular dysplasia. That means the acetabulum, which is this, it can get underdeveloped in this patient. And if it get underdeveloped, eventually the child can develop premature osteoarthritis, which is very complicated. Okay, so that's the complication that can happen in a DDH patient, and that's why we do this screening test. Clear, everyone? So if you get an X-ray like this, where you can see that it's very easy to understand. Like if you compare this, you can definitely see that this hip is well located, but this one is definitely dislocated. Okay. Next, Perthes disease. Perthes disease is avascular necrosis of the femoral head. So if the femoral head become necrosed, so it's common in male child between 4 to 8 years. Child will come to you with a hip pain and limping, and they will also have difficulty to do certain movement, especially abduction and internal rotation. So if you do an X-ray, if you might be able to see the necrosis. If you see that this one, the femoral head is convex and round and smooth, but if you look on this side, you can see that it's completely destroyed, right? That's avascular necrosis of the femoral head. So if you get something like that, that is what we call as Perthes disease. So if you get this kind of X-ray, refer urgently to the orthopedic, and the choice of treatment will be depending on the severity of the condition. Left untreated, it will eventually cause osteoarthritis in a child. So they might need to put on a cast or a splint. Next, transient tenosynovitis or transient synovitis. So transient synovitis is also called irritable hip. So it's a very important topic for the exam. So transient synovitis, again, it's common between 4 to 8-year-old. Child will come to you with a sudden onset hip pain and a limp. Maybe they will be able to walk, but with pain. So it will not be severely painful like septic arthritis. Excuse me. But the very important finding that they will say that maybe in the last 1 week, the child having a recent upper respiratory tract infection. So recent history of flu-like illness followed by hip pain, your first thing should be transient tenosynovitis. So in transient tenosynovitis, you need to do further investigation to make sure it is nothing abnormal. So you do a blood test. You can also do a X-ray, ESR, CRP, and an ultrasound. So blood test mainly to look for any sign of infection into the joint, X-ray, and ultrasound. So you need to do all of these things to make sure there is no significant inflammatory marker or infection marker. Because if it is, then it could be a septic arthritis as well. So this is quite normal. There is nothing we need to do about it. Just reassure the patient and it will get better within a week. So treatment is bed rest, use of crutches and analgesics, but you need to do a follow-up X-ray in 4 to 6 months to make sure that this is not a Perthes disease. Okay? Now, the problem in the exam, what happens is just because that there is a history of viral illness doesn't necessarily mean that it is always transient synovitis. The symptom will be important. So if the child is unable to move the joint at all, so quite restricted, significant pain, with or without fever, doesn't matter. Even if you think that this is transient synovitis, you have to consider the possibility of a septic arthritis. So what would you do is you send the patient to the hospital, and the hospital will do a aspiration from the joint, like a synovial fluid aspiration, and then they will send it to the lab for microscopy and culture. So aspiration will be needed to exclude septic arthritis in this kind of case. Okay? So just because the child had a viral illness, don't just think it is transient synovitis all the time. So you have to make sure that you're ruling out the possibility of a septic arthritis. Definitely, if the child is able to walk, bear weight on the leg, that's unlikely to be septic arthritis. Septic arthritis child will be severely unwell, lot of pain, will not be able to even move the joint at all. Then you would think that it could be septic arthritis. Okay. Does it make sense for everyone when to consider septic arthritis? While we are on this topic, let's discuss this. So septic arthritis of the hip should be suspected in all children with acutely painful or irritable hip. The patient may not be obviously sick on presentation, especially infant less than 2. A negative needle aspiration does not exclude it. If sepsis is suspected, it is better to proceed to an arthrotomy. The irritable hip should be diagnosed only after negative investigation, including plain X-ray, ultrasound, full blood examination, ESR, and bone scan. Needle aspiration has to be considered, but irritable hip is often diagnosed without it by observing the child in hospital in traction. If deterioration or elevated temperature develop, needle aspiration with or without arthrotomy is indicated. So that's the main thing. So we can't diagnose irritable hip or transient synovitis without ruling out a septic arthritis. So if the child having features of synovitis, you will send the child to the hospital and they will consider what they want to do. So you will start with a blood test, X-ray, ultrasound, and if the child doesn't have any fever, then you can just put the child in as an observation in the ED. If child starts to get more pain, fever develops, then you will proceed for the needle aspiration with or without arthrotomy. That means sometimes you might need to just do a washout of the joint to reduce all the pus and everything. Okay. Now, so now that you understand when we diagnose septic and when we diagnose transient synovitis, let's go to slit capital femoral epiphysis, SCFE. So this is a displaced epiphysis of the femoral head. So left untreated, patient sometimes what happens that when patients develop avascular necrosis of the femoral head, sometimes the epiphysis of the femoral head can get displaced. So something like this. Let me show you a good X-ray of this. So you can see here, so that's the epiphysis over here, and that's the femoral head. So you can see the femoral head has got displaced or it has slipped. So when femoral head or the epiphysis of the femoral head slipped from the rest of the femur, that's what we call as SCFE. Does it make sense for everyone? Now, this SCFE is common in adolescent, so 10 to 15-year-old and mostly obese children. So obese athletic child, 10 to 15 year, they are the one who can get it. So patient will come to you with a pain on the hip. Sometimes they can also come to you with a knee pain in this condition. So if a child having knee pain, especially obese child, don't forget that it could be a referred pain from the hip. Okay. So most of the movement of the hip will be restricted, but especially internal rotation will be mainly affected in this case. So any adolescent with a limb or knee pain should have an X-ray of their hip as well. So definitely we'll do an X-ray of the knee, but you should also consider doing a like a hip X-ray. Otherwise, this important condition can be overlooked. So sometimes it is not like always that the X-ray that I have shown you, so it will be the case. So this is like a severe form of it. What if it is the initial form? So initial form can be diagnosed in this way. So if you draw a line on the top of the neck of the femur, that line should go through the femoral head in a normal patient. But if it is SCFE, then it will go above the femoral head. Okay, so if the line goes through the head, that's normal. But if it goes above the femoral head, there is also SCFE. Management, so advise the patient not to bear weight, refer urgently to an orthopedic surgeon, and this patient definitely will need a reduction and traction. And sometimes even they will put a pin into the femoral head to keep it in position. Okay, so that's all about the childhood hip pain. Any questions so far? So elderly hip pain. So one of the commonest cause of hip pain in elderly is osteoarthritis of the hip. So it is the most common form of hip disorder in an elderly patient. So it's mainly wear and tear of the joint. So common after 50, increase with the age. It's the insidious onset, so chronic onset. At first, the pain will increase after activity and relieved by rest. And then a nocturnal pain will appear and pain will even happen after rest. Patient can have stiffness in the morning. So it's not uncommon. So it's very common for the elderly patient to come to you for a chronic hip pain, and then pain can start to cause like nocturnal pain at some point. Patient can also have like initially their hip movement that's going to be lost is internal rotation and extension. Because internal rotation and extension is painful, their hip sometimes will be kept as flexion and external rotation. That means the opposite of this movement. Eventually, all movement will be affected. So osteoarthritis of the hip, it's the characteristic of the pain which gives you the diagnosis. So elderly patient coming to you with a chronic hip pain, and the pain gets better after rest, worse with activity, and at some point nocturnal pain is started with a bit of morning stiffness, then you think of osteoarthritis. So there is no specific cure of it. So what we do is that initial treatment is like you can give them some simple pain relief, so paracetamol, and a very short course of anti-inflammatory. You can send them to a physiotherapist to do some muscle strengthening exercise. So that's the initial treatment. And the last resort, especially if it is a severe or advanced osteoarthritis, then most of these elderly patients will need a hip replacement. Okay? So that's osteoarthritis. Next, there is another hip pain which is very commonly found is greater trochanteric pain. So let me show where is the greater trochanter. So you can see that this is the hip joint. Just the bony prominence on the lateral aspect of the hip is greater trochanter. And on the top of that, there is bursa. So patients sometimes can have this greater trochanteric pain syndrome. Okay. So the pain will be on the lateral aspect of the hip, and patient will say that whenever they lie on that side at night, it causes very pain. Okay. So it's a lateral hip pain. Sometimes it can even radiate down to the lateral aspect of the thigh. So the cause is tendinopathy. So the tendon that gets connected on the greater trochanter, sometimes that can get strained. So you can see the tendon. So this is the gluteus medius tendon which gets attached over here. Okay. So sometimes the gluteus medius tendon can get inflamed and strained, causing this pain. Sometimes the bursa can get inflamed and it can cause trochanteric bursitis, and the pain can be more or less same. So if you do an X-ray, that will be normal, but if you do an ultrasound, ultrasound will confirm that if there is tendinopathy or bursitis. So it's common in older elderly patient, pain on the outer side of the hip, pain on lying on the hip at night. It can be also painful when they climb the stair or getting in and out of the car. And also very important finding is that if you press on the lateral side of their hip, it will be tender. So treatment, you can give a trial of NSAID, and physiotherapy is the first line treatment. If that doesn't work, you can also send them for a steroid injection into the bursa. Okay. So that's all about hip pain. Any questions so far, guys? Are you guys understanding, or is it very difficult for you? I can understand from most of your silence that you're pretty stressed about ortho, but see that it's not very hard if you know the basic of it. So don't feel overwhelmed. Okay? Role of CBD. It's a adjunctive treatment. Sometimes we can send them for a psychological assessment, especially if there is a lot of pain, but it's not the most important thing to do. Okay, let's take a 10-minute break and then we will start with the leg pain. Thank you. All right, everyone, let's start again. So we are starting with the leg pain now. Dr. Chandima, so all children with hip pain need to be admitted. It's not like that. It's mainly acute hip pain in a child. Then you need to make sure that you rule out a possibility of a septic arthritis. And definitely it depends on a lot of other factors also. It's a very, like if we just say every children with a hip pain needs to go to the hospital, that's not going to work. So definitely depends on a lot of other factors and whatever given on this stem. But as a general thing, acute severe hip pain in a child, we need to make sure that we rule out septic arthritis. Leg pain. So, leg pain can be due to a lot of causes, but the most important two things that we want to rule out is it an arterial problem or is it a neurological problem? So sometimes it could be like a vascular claudication because patient having like a peripheral vascular disease. Sometimes it could be the back pain, which is referred to the lower leg and causing a neurogenic claudication. All right. So nerve entrapment. So if someone has got sciatic nerve getting entrapped in their lumbosacral plexus, that can also come into the leg as a radiating burning pain, which is often worse at night. Older people can present with a claudication or pain in the leg from spinal canal stenosis. They can also come with arterial obstruction. The commonest site of acute arterial occlusion in the lower leg is common femoral artery occlusion. So let's move into the vascular problem. So definitely you understand that like the leg has got vascular supply, so arteries and veins. So we are talking about arterial ischemia. So if there is it's like a severe ischemia happens on the lower leg, it can be either due to thrombosis, like a complete blockage of a particular artery that supplies the leg, or could be an emboli coming from somewhere else, maybe from the heart, and blocking that artery. So in an acute severe ischemia, patient will suddenly come to you with an acute severe lower leg pain. All right? And sometimes you will also get no pulse. So acute severe lower leg pain, you should make sure you rule out possibility of a acute severe ischemia. And then most of the patient has a chronic ischemia due to arterial occlusion. So they can have atherosclerosis and they can have lack of blood supply to the lower leg, which is normally we call it as PVD or peripheral vascular disease. This patient who has chronic ischemia, they present as intermittent claudication, which means whenever they walk, they get the pain in the leg, and then when they take rest, the pain disappears. So that's intermittent claudication. So you can see here that arterial occlusion can happen any part of the lower leg. If it happens on the high areas or proximal iliac artery, or it's getting obstructed in the femoral artery. So especially if it is a high obstruction, the pain will be felt on the buttock, thigh, and also the cuff. So pain will be distal to the arterial obstruction. If someone has got obstruction in the thigh, which is superficial femoral artery obstruction, so the pain will be on the lower leg. Okay, so it always depends where exactly is the obstruction, and distal to that obstruction, patient will get the pain. It's very important to know how to differentiate between a vascular claudication and a neurogenic claudication. So vascular claudication is due to like arterial obstruction. Neurogenic claudication is due to spinal canal stenosis. So if the canal where the spinal cord lies, if that canal gets compressed or get narrowed, it can also give symptoms in the lower leg. So the patient who has a spinal canal stenosis, their main symptom should be a long history of back pain. And the pain will start from the back and then it will go to the buttock, then the thigh, then the lower leg. So It goes from proximal to the distal. Okay. This pain also can get worse after walking. So that's why it get confused with a vascular claudication. So both uphill and downhill walking can make it worse. Prolonged standing can make it worse. And it is relieved by either taking rest. So 20 to 30 minutes after taking a rest, usually it starts to get better. And also lying down will make it better. Okay. Now coming back to the vascular claudication. Vascular claudication is due to atherosclerosis, and it most of the time happens in the distal part of the leg, and then it radiates proximally, which is a bit different than the neurogenic claudication. So vascular starts distally and radiate proximally. The type of the pain is very important. Vascular pain is usually cramping, aching, and squeezing pain. Neurogenic pain is mostly tingling, numbness, and weakness, never cramping. Okay. And vascular claudication, the pain will get worse after walking at a distance, especially uphill. And if the patient takes rest, usually very fast relief of the pain will happen. So it will not take 20 to 30 minutes like neurogenic claudication for the pain to get better after a rest. If you do the physical examination, definitely for neurogenic claudication, their pulse will be fine. Vascular claudication, pulse can be present, but sometimes it can be reduced or absent as well. And if you do a neurological examination in spinal canal stenosis, sometimes you can get some neurological finding. Even the ankle jerk can get reduced. But for vascular claudication, neurological finding will be normal. How to diagnose? So if you think it is spinal canal stenosis causing the neurogenic claudication, the big MRI. Okay, so radiological studies, the best would be CT or MRI, which can confirm the diagnosis. And if you're thinking of vascular claudication, you would start with a Doppler or duplex arterial ultrasound. So duplex arterial ultrasound is the initial test. And if you think that there might be a severe vascular ischemia, then sometimes even we do a CT angiogram or CT aortogram. Okay, so that's the investigation of choice. Now moving on a little bit more, we will come to the vascular claudication just in a bit. So why impotency? So if the blood supply in any kind of artery can get impaired. So if the penile arterial supply gets impaired, then the patient can have impotency. Now, have a look that if a patient complains that the patient having the pain, so the pain on the lower leg get worse on standing, we consider a spinal cord. If it worse after lying down, we consider vascular origin, because when they lie down, because of like more gravity, the pain can get worse. Pain unaffected by posture is activity related. If it is worse on sitting, consider a spinal cause like a disc prolapse. Okay, so this is just a bit of idea. It's not the confirmatory thing. But if a pain get worse on standing, we would think of a spinal cause. Okay, just like the cervical or neck pain, when we come to the lower leg pain, we also need to know the dermatome of the lower leg. So lower leg dermatome is important to know. So I will give you a basic idea so that you can remember. So let's say this is the leg. Sorry for this drawing. Okay, so what's happening in here? So we are talking about the the lower leg dermatom. So over here, you have got L2, so anterior portion of the thigh. L3 is mainly anterior part of the knee. L4 is medial part of the lower leg. L5 is the outer part of the lower leg. So these are all sensation that we are talking about. So L5 supplies the outer part of the lower leg, including the dorsum of the foot. The only thing it doesn't supply is just the lateral part of the dorsum of the foot, which is supplied by the S1. And also sole of the foot is supplied by S1. Okay, so that's the main dermatomal finding or dermatomal nerve distribution for lower leg. So L3, because it supplies the knee, it also helps with knee extension. L4, which supplies the inner part of the lower leg, helps with flexion of the knee and inversion of the foot. Now this function you need to memorize, because many times they will give you a scenario and then they will ask you what kind of radiculopathy it is. So if you don't know the nerve root functions, then you will never be able to find it out. So if a patient having pain or tingling numbness sensation in the lower leg, and you can see the patient's flexion of the knee is weak and also inversion of the foot is weak, there is bit of lack of sensation on the inner part of the lower leg, that means it is L4 radiculopathy. How about L5? L5, it supplies the outer part of the lower leg, including the dorsum of the foot. So its main function is dorsiflexion of the ankle. Not only just dorsiflexion of the ankle, it also helps with inversion and eversion of the foot. Okay, so all these dorsiflexion, inversion, eversion is done by L5. S1 is mainly supplying the lateral part of the front of the leg or dorsum of the leg, and also definitely the sole of the foot. It causes plantar flexion of the ankle and also sometimes eversion of the foot. Okay, I know it is quite complex. I don't think you need to memorize all of this right now. Just remember that this is what you need to read at some point. Now that you have a basic idea about the dermatom of the lower leg, let's discuss sciatica. So sciatic nerve comes from the lumbosacral plexus, and the root value of this is L4, L5, S1, S2, S3. Now for understanding this, you need to have a good knowledge about the sciatic nerve. So this is the sciatic nerve. You can see that from the lumbosacral plexus, L3, L4, S1, S2, S3, all these nerve root, it combines together and becomes the sciatic nerve. Sciatic nerve runs through the back of your buttock, then the thigh, and then when it comes at the back of your knee, then it divides into two main branches. So it divides into posterior tibial nerve. So this one is posterior tibial nerve, and then it goes to the anterior part of the leg and makes it as a common peroneal nerve. I will come to that later on, but just remember that sciatic nerve runs through the whole posterior part of your leg. So if someone has got sciatica, that means the sciatic nerve has got pinched in their back. So in patient with sciatica, patient will have a acute severe lower back pain, and the pain will be like an electric shock like pain, which is radiating from the lower back, then the posterior thigh down to the foot. So acute sciatica means up to 12 weeks or 3 months. So for that case, conservative treatment is all that you need to do. So you can put the patient for maybe 2 days of bed rest and then return to usual activity. Give them some analgesics, paracetamol, NSAID. send them for exercise program. Okay. Chronic sciatica, if a trial of NSAID, rest and physiotherapy has not brought significant relief, you can even send the patient for a epidural anesthetic with a steroid injection into the sciatic nerve. Okay. Now, anytime if there is numbness, there is weakness, that means there is neurological deficit is there. In that case, you might consider doing a imaging such as CT or MRI. But just to diagnose sciatic pain, you don't need to do anything. So it's just like a clinical diagnosis. Okay. So we're talking about the lumbar spinal canal stenosis. So a spinal canal stenosis is narrowing of the spinal canal, resulting in pressure on the sciatic nerve root and possibly the spinal cord. So let's have a look what happened in a spinal canal stenosis. So this is the spinal canal, and you can see the spinal cord is over there. So sometimes, like, could be due to multiple things. So if the canal get compressed or canal get narrowed, it can start compressing the spinal cord. So basically, you might start to get a cord compression symptom, which means where the compression happens, along this area, you get lower motor neuron type of palsy, but distal to the compression, you get upper motor neuron type of features, which means both. So this is on the lumbar area, right? So patient will have the neurological finding like spastic paraplegia, then patient will have hyperreflexia, hypertonia on the lower leg bilaterally. So that's one of the worst complication that can happen with this canal stenosis. Not everyone gets it, but when it happens, you need to send them for a urgent review. So the symptoms will be pain, which is usually bilateral in the proximal leg, buttocks, thigh, and legs, radiates distally. So it starts from the back and then go to the leg. Conservative treatment is rest, exercise, analgesics. Surgical consultation is mainly needed for someone who has got progressive neurological deficit or any feature of like a acute cord compression. Now, if you get a patient who has got this kind of symptom like canal stenosis symptom, then best is to get a CT or MRI for that patient, and that will give us the best idea that how much damage it is. For spinal cord, always MRI is the best. Okay, but as an initial investigation, you can do a CT. So if you want to look into the nerve, X-ray can't look into that. CT and MRI can do. If you want to look at the bone, X-ray is good, CT is best. No, sciatica is sciatic nerve compression, and canal stenosis is the canal where the spinal cord lies is getting narrowed. So it's a okay. Moving on to some nerve entrapment syndromes. So one of them, which is very common, is meralgia paresthetica. So what is meralgia paresthetica? It is one of the commonest nerve entrapment in the lower leg. So the lateral femoral cutaneous nerve of the thigh, if that nerve which supplies the lateral part of your thigh, so this part, get entrapped under the inguinal ligament. So the nerve which passed through here under the inguinal ligament, if that gets trapped, the patient will come to you with a tingling numbness sensation on the lateral part of this leg. Okay. So it is most common in middle-aged patient associated with obesity, pregnancy, ascites. Sometimes even if a patient puts like a very tight belt or trusses, it can cause it. So patient comes with a burning pain with numbness and tingling on the lateral side of their thigh. The way to confirm the diagnosis is that pain will be localized to a specific part of the thigh and never cross the midline of the thigh. So treatment, injection of steroid under the inguinal ligament, that's the treatment of choice. And if it is really bad and steroid injection doesn't do much, surgical release is the treatment. Okay, so that's meralgia paresthetica. Next, very important for exam is common peroneal nerve entrapment. So common peroneal nerve can be entrapped where it comes forward to supply the anterior portion of your leg, which is around the neck of the fibula. So let's have a look. So you remember I was talking about this. So the sciatic nerve get two branch. One branch goes to the posterior part of the leg and another one comes forward. So the common peroneal nerve, it turns forward around the neck of the fibula, so over here, and supplies the anterior part of your leg. Okay, so the whole anterior part of the leg, including the dorsum of the leg, is supplied by the common peroneal. Common peroneal nerve later on gets two branch. One is superficial peroneal nerve and another is deep peroneal nerve. Okay, now superficial peroneal and deep peroneal and common peroneal. So let's say common peroneal nerve, the function or the motor function of this is eversion and dorsiflexion. So eversion of the foot and dorsiflexion of the ankle. So that is common peroneal motor function. Now eversion, or you can say the dorsiflexion, is done by deep peroneal nerve and eversion is done by superficial peroneal nerve. Does it make sense for everyone? Okay, so common peroneal, which supplies the anterior portion of the leg. So what is the supply of superficial peroneal and deep peroneal? It means the sensation. So the superficial peroneal supplies the whole leg, the whole anterior leg, except the first interdigital space. So this part, and this, only this part is, the sensation is done by deep peroneal nerve. Okay, so that's the motor and sensory function for common peroneal. So a patient who has common peroneal nerve entrapment, they're the one who, someone can have a like a fibular trauma or injury. So if someone get injury to the knee, it can cause it. Someone who sits for a long time, like someone who is like a strawberry picker, they might need to squat for a long time to pick up all the fruit, and they can also get this kind of problem. So prolonged squatting is one of the risk factor. So patient will come to you, the main symptom will be like lack of dorsiflexion of the ankle. And if they can't do dorsiflexion, they will have this like foot drop. So their foot will be dropped. So foot drop is the main presentation for this case. Apart from that, they can also come to you with a pain in their anterior portion of the leg. They can also have loss of sensation or paresthesia or numbness. And they will have weakness of eversion and dorsiflexion of the foot. The only thing that can get confused with this one is L5 nerve root problem. Because L5, if you remember, also helps with dorsiflexion of the ankle as well as inversion and eversion. So if L5 radiculopathy is the case, that patient also will have foot drop. So how will you differentiate between L5 and CPN? The way to differentiate is that L5 only supplies the lateral part of the leg, not the anterior part of the leg. The other one is L5 supplies dorsal flexion, like it helps with dorsiflexion, inversion and eversion, whereas common peroneal does not help with inversion. Okay, that's usually the only way to differentiate between these two. L5 doesn't have any reflex or jerk. CPN also does not help with any reflex or jerk. So in both of the case, reflex will be fine. Does it make sense for everyone? So how the common peroneal nerve entrapment will present and how to differentiate it from L5. Okay, moving on to tarsal tunnel syndrome. So tarsal tunnel syndrome is, see that this is just at the medial part of the ankle. This is the tarsal tunnel. Underneath the tunnel, posterior tibial nerve passes and it goes to the leg or goes to the foot. So if the posterior tibial nerve get entrapped into this tunnel, that's what we call as tarsal tunnel syndrome. So patient will come to you with a burning, tingling pain in the toes and sole of the foot, and they mainly will have discomfort at night and worse after standing. The removal of the shoe may give relief, and mainly for this kind of case, posterior tibial nerve helps with plantar flexion. So plantar flexion can be impaired. The sensation of the sole can be impaired. So that can be the finding. Sometimes we do a Tinel tap test that can be positive in this case also. Same like carpal tunnel syndrome. If you want to confirm the diagnosis, you have to do either you can do a nerve conduction study or electromyogram. Not very important. Okay. Moving on. Are you guys with me so far? You are understanding everything? Moving on to arterial occlusion. So there are lots of risk factors for peripheral vascular disease, but smoking is the most important one. And apart from that, diabetes, hypertension, high cholesterol, beta blocker, every one of them can cause like a little bit of worsening of the arterial occlusion. So first of all, acute lower limb ischemia. How would we think that this patient has got acute lower limb ischemia? So acute lower limb ischemia depends on 6P. So sudden onset of severe lower leg pain, pallor, paresthesia or numbness, pulselessness, paralysis, perishing cold. So if there is 6P in a leg and it's a very acute sudden onset, then you would think of acute lower limb ischemia. What is the main or most important sign for acute lower limb ischemia? Paralysis and the muscle compartment pain is the most important sign. So this comes in exam. Okay. So if you have found a patient who has got acute lower limb ischemia, what would you do? Definitely, in those cases, you need to send the patient to the hospital immediately for a vascular surgeon referral. Under the vascular surgery, most likely patient will get a CT aortogram, CT angiogram to confirm the diagnosis, and then further treatment will be done. We'll come to that later on. The commonest site of acute occlusion is the common femoral artery. So this also comes in exam. So to find out if a patient has got PVD, we do a test called Burgard test. If Burgard test is positive, it indicates patient suffering from chronic severe lower leg ischemia. So if a patient has acute lower limb ischemia, it is still reversible if you can treat the patient within 4 to 6 hours. So that is the golden hour. After 6 hours, most likely you would not be able to do anything and patient might need an amputation. So if you suspect occlusion, the treatment is intravenous heparin, emergency embolectomy. Sometimes they can put a stent to keep the artery open, or even sometimes a bypass grafting. For this patient, they might need a lifelong warfarin. So acute lower limb ischemia is important. So try to remember the 6P, and if that is the case, definitely send the patient to hospital and they will do the further treatment. How about chronic lower limb ischemia? Chronic lower limb ischemia comes with intermittent claudication, so which means pain on the lower leg after walking and get relieved by rest. But a little bit severe form of this is resting pain. So even after rest at night, patient having a constant severe burning type of pain in their foot. And that is also bad. So intermittent claudication is the start of PVD, where patient starts to get the pain after walking and gets relief after rest. But gradually it will get more and more worse. And at some point, even at night when they are resting, the pain will become constant. So that's wrist pain. So we know about, like, if there is an obstruction in the proximal artery, the pain will start on the buttock and then goes downward. If there is obstruction of the superficial femoral artery, which is on the thigh, the pain will be mainly on the calf. Okay. So lots of causes, but most importantly, atherosclerosis is the main cause of PVD. Could be embolizations, Berger disease, and those are important. Not important, you can go through it. Now let's say you suspect a patient to have PVD. What will be your investigation? So initially, you can do a ankle brachial index. And if ankle brachial index is less than 0.9, that can give you an idea that, well, this patient most likely has got lower limb ischemia. Then the next step is to get a color Doppler ultrasound of the arteries, not the vein. So if you get a Doppler arterial ultrasound, it will say that yes, there is a stenosis or peripheral vascular disease. And then let's say someone has got a severe ischemia, like their ABI is less than 0.5, and patient having like significant pain and some other features which we will discuss. In those cases who might need a urgent intervention from a vascular surgeon, you need to do a angiography. So confirmatory or best test is CT angiogram or angiography, but it is only reserved for someone who is very severe. Someone who is not severe, like patient whose ABI is more than 0.5, all you do is a Doppler ultrasound. So what will be the management? So smoking has to be stopped. That's the first thing that you need to ask the patient to stop. Then also we do this like supervised exercise is very good. Reduction of body weight is important. You can see arteriography should be performed only if surgery is contemplated. So arteriogram is mainly reserved for severe case. So treatment for PVD, especially for mild to moderate one, is no smoking, graduated exercise. You can give them aspirin, which will reduce the clot formation. So that's mainly the treatment. Okay. So when will you refer to the vascular surgeon? If a patient has got unstable claudication and it's deteriorating, so severe pain in the leg, resting pain, or if there is ulcer, gangrene in the leg, these are the time when you need to do a CT angiogram followed by a referral to a vascular surgeon. Same if ABI is less than 5, that also say that yes, likely to be a severe ischemia. Okay. So this comes in exam a lot. Like they want to know that when to do Doppler, when to do CT angiogram or arteriogram. So surgery is mainly for someone who has got intolerable claudication. They have got severe pain. The surgery can be sometimes stenting or bypass grafting, even sometimes endarterectomy. We normally say that grafting is mainly for proximal arterial occlusion and stenting is mainly for distal arterial occlusion. Okay. Yes, so initial is ABI if that is in the option. So that's all about vascular occlusion. Moving on to varicose vein. So all of you know about varicose vein. So those are dilated tortuous superficial vein in the lower leg. Common in female patient who is pregnant, multiparous. So those are the common patient. Prevention is maintain ideal body weight. The treatment. So first of all, if you suspect a patient having varicose vein, you can also get an ultrasound to know how bad it is. If it is not that bad, so initial treatment is supportive stocking, which is compression stocking. And that's usually the main treatment. If that is not working and patient having severe varicose vein, one option, especially for like varicose vein below the knee joint, and it's just one isolated vein, which is the problem, you can also go for a sclerosing therapy. That means like you might need to just insert some sclerosing chemical which will reduce the varicose vein. So that's called compression sclerotherapy. But the best treatment, especially for like above knee varicose vein, is always surgical ligation and stripping. Okay, so just remember the name of this treatment because sometimes it can come. Next, superficial thrombophlebitis. What if this superficial vein get inflamed? So if the superficial vein get inflamed, especially the superficial varicose vein, it can present as a tender red subcutaneous cord in the leg. So it will look something like this. See this one? So the varicose vein can get red and tender. So like this. So patient will be a non-varicose vein patient, but then the varicose vein becomes very red, painful, and tender. So that's superficial thrombophlebitis. So for this patient, there is always a risk that they might have a clot in the deep vein. So that's why you need to make sure that you do a venous duplex scan to rule out any possibility of a underlying DVT. So treatment, apply a firm elastic bandage. If it is a spontaneous thrombophlebitis, then the patient needs to be on low molecular weight heparin for 4 weeks. Okay. If it's due to a complication of IV infusion, and usually happens in the arm after a cannula, then at the time you just put them with some NSAID, like a topical NSAID gel. Okay. But for the lower leg, and if it is a spontaneous one, you need to do a low molecular weight heparin for 4 weeks, just to make sure that they don't develop any clot. No antibiotic. So antibiotics is for cellulitis. So cellulitis comes with like red, swollen, hot, and tender leg or tender area. So cellulitis will look something like this. So what is cellulitis? It's a subcutaneous tissue infection. So you can see that this is how cellulitis will present. Okay, so red, hot, tender, swollen area in the leg. Most of the time, it is due to a Streptococcus pyogenes or Staph aureus. For this kind of patient, yes, you will need to ask the patient to elevate their leg to reduce the swelling, give some paracetamol for the pain and fever, and for this patient, you will need to put them with antibiotics, so phenoxymethyl penicillin or dicloxacillin or flucloxacillin. Okay. DVT. So deep vein thrombosis also very important for exams. There is a lot of risk factor for DVT, but one of the most important one is that if someone has got a major orthopedic surgery, like someone who has got a recent hip or knee replacement and coming to you with a sudden onset of cough, redness, swelling, and tenderness. So sudden onset of cough, pain, redness, swelling, you would think of possibility of a DVT. Apart from that, you can also think of someone who has got malignancy, some of the drugs such as HRT, tamoxifen, OCP, previous history of DVT, all of this can be risk factor. So if you suspect that patient can have a DVT, what would you do next? So the next step is you do this test called duplex ultrasound. So you do a venous duplex ultrasound, and venous duplex ultrasound can confirm DVT. Okay. We don't need to do a D-dimer in this case. So your test would be duplex ultrasound. So if duplex ultrasound confirm that this patient has got a deep vein thrombosis, what would be the treatment? So the treatment for this patient, so you can either put them with low molecular weight heparin such as enoxaparin, unfractionated heparin, or commonly nowadays we use newer oral anticoagulants. Although JM says about heparin and warfarin for DVT, nowadays we don't use this as our first line option. The first line treatment for DVT at the moment is newer or direct oral anticoagulant. So newer oral anticoagulant such as apixaban, rivaroxaban, or dabigatran, same as pulmonary embolism, guys. So that will be the treatment of choice. Okay, not heparin and warfarin anymore. And the treatment for this newer oral anticoagulant, if it is a provoked DVT, like sudden patient had a surgery in the lower leg and then patient had a DVT, that means we know the cause. For provoked DVT, just three weeks is enough. Or sometimes we go up to 6 weeks. So 3 to 6 weeks is the treatment. But if it is a unprovoked DVT, then 3 months. Okay. So that's all about leg pain. Leg pain is very large and there is a lot of questions come from here. So give a little bit more attention to this chapter. Okay. So to think of DVT, there has to be some risk factor. Okay. Without a risk factor, we don't actually think of DVT. Like cellulitis is common in diabetes patients, but clinically it is sometimes it can be quite difficult to differentiate. But cellulitis can happen in any part of the leg, whereas DVT is common in the calf. Okay, so that's one of the way to know. The other than that, there is no specific physical examination that you can do to differentiate this. Fever can be there in cellulitis, that's common. Even sometimes DVT patient can have a fever, so you can't just rely on that. So risk factor is important in these cases. Okay, I don't think we should be, we can finish the other part of the orthopedics. So there is still knee and ankle pain that is left. And We will see if we can finish it as part of our end of course. So many times if something we can't finish in the class, we finish it at the end of the class. So we'll try to finish it during that time. But if you want to go through the foot or ankle, foot and knee pain, then on the previous video lecture, there should be discussion about this in our previous batch. So you can also go through that video lecture. Okay. If it is not, I can't recall that if I was able to finish it in the last batch. Most likely not. If you don't find it out, let me know in the next class. Then I should be able to give another video in your portal where we have discussed those two topics. Okay. So that's all about the orthopedics for tonight. Any questions? So try to finish these things as soon as possible because it is still quite like you would be able to remember everything that I have said in the next few days. So I would definitely advise you to go through these topics within this week so that it's nice and easy for you. If you keep it for a month time, this will become like completely new topic for you. Okay. Thank you everyone. We'll finish it here tonight. Take care. Any topics self can cover is which is important. Usually, like most of the important topics will be discussed by me in the theory session. But if there is any topic which we don't discuss in the theory but comes up in your recall session, then definitely go through that by yourself. How many subjects left? I can't give you the exact numbers, Dr. Faria, but yeah, you will get the schedules along the way. The course is going to be finished in first week of August. So still you have got how many months? So June, July. So at least 1.5 months. For red flag, we like those red flag that has been given, it's X-ray is the first test. The only time MRI is directly done if there is a possibility of a spinal cord compression. So that is the only time you will directly send the patient for a MRI. All good, everyone. Thank you for tonight. We'll stop it here today. Take care. Have a good night.